Dr. Chandra Bondugula, ZeaMed Founder and CEO, was a moderator recently at the Alabama Healthcare Executive Forum's webinar on price transparency. He spoke with Dawn Bulgaraella, CFO of UAB Health System, and William Horton from Jones Walker LLP. Here they discuss the new CMS price transparency law that's supposed to go in effect January 1st, 2021. Let's listen.
It's important to note that price transparency requirements are not new. Going all the way back to 2006, CMS actually began publishing information about transparent prices. And so we can debate what the definition of prices here is as we go along. In 2006, they actually identified 100 of the more common inpatient services that were provided and published the differences across the country in terms of what hospitals were submitting in terms of charges. Now, for those of us involved in hospital charges, we certainly recognize that what a hospital charges and what a hospital costs are not the same, but nonetheless, it goes all the way back near 14 years now. In 2019, we were all required to publish online in a machine-readable format a list of all of the hospital charges. It couldn't be hidden behind a variety of web screens, but had to be readily available to consumers if they wanted to access it. And I dare say for those of us in the hospital business, while we did have a few individuals to access it, it's very complicated, and unless you have a medical background, it's almost irrelevant data to the individual consumer. Most of us had some media inquiries where the media would appropriately go out and try to evaluate what the cost of something was at University Hospital, in my case, in comparison with other local, regional, or even state hospitals, so that they could accurately compare what were we charging. But again, I think as we all know, what the consumer was paying for those charges oftentimes doesn't have a real relationship to what the charges are.
That hospitals were going to be required to disclose charge master prices. And you were going to get this list, and it was going to be put in a consumer-friendly format. And it wasn't actually going to tell you that much of anything, because charge master prices don't tell you that much of anything. And it would be kind of a pain in the neck, but it would be there. Consumers could access it for whatever it was worth. You were required to put it up in a consumer-friendly format, because while everybody was sort of resigning themselves to, okay, we're going to have to take this data, this information, and format it in the way CMS wants to see it, and we're going to have to put it on our website, and we're going to have to, be under some fairly tight constraints on where it has to show up and how it can be accessed. The argument, of course, and there is merit to this, is as more and more people have high deductible plans, more and more people have medical savings accounts, more and more people are seeing benefit reductions, even if they've got an employer-based plan, benefit reductions, and narrower networks. There's an argument that, well, it makes some sense for people to be able to go and actually shop their out-of-pocket cost in an intelligent way.
Bill and Dawn, thank you so much for the insights. Actually, it's very helpful. Dawn, you're a leader of the big system. UAB is well positioned for this requirement. So how do you see the smaller hospitals taking this responsibility and challenge? So what kind of resources they need?
I think the hospitals have the challenge of, do they have the expertise in-house, not only to pull the information, because I think that most in the financial space could pull the information, what are my charges, the number of man hours that it will take to go in and decipher the contracts that you have and put those alongside of your charges. So Medicare and Medicaid are off the table, but even if you have 20 managed care contracts, they're not as straightforward as X percentage of charges. I mean, they have all sorts of nuances in them. So do you have the expertise and the man hours in-house that you can pull that information together? Would be step one. And then if you do you have the website and the IT ability, if you will, to maintain that on your website? I mean, we, as large as we are, you can imagine the largesse of our charge master and then all of the managed care contracting information that's there. So while we certainly have individuals that will put that appropriately on the website and make it in a user-friendly or as user-friendly as you can. And then the last piece of it would be the communication. How do you communicate with your leadership of your hospital, your board members, your patients, your physicians, and that sort of thing? What's going to be out there, and then the nuances that come with that. So I can tell you that there are a great number of third-party consulting companies, third-party vendors that very quickly recognize what this requirement was, and they're selling those services, and so that might be a viable option for you. I don't think Bill referenced it. It wouldn't surprise me if there are some hospitals that say don't have the manpower, not going to do it. And if you are discovered in a CMS audit that you haven't done it, the fine is $300 a day. And so is it worth $300 a day until you could get something up? Probably more than anything, not only the $300 a day, but then you're listed on the CMS website as non-compliant. I don't think anybody wants that designation. So if you're just now getting started, maybe you've waited long enough, like Bill referenced, that we thought that this was going to get overturned, particularly with the pandemic. We thought this would get delayed. It doesn't appear that it's headed in that fashion. You may not have enough time on your own at this point, so you may need to reach out to someone, to a consultant firm or something along those lines.
And we have one question from the audience. So, given the complexities around hospital billing and charges, facility, professional, etc., do you think this legislation will help consumers or just cause more confusion?
Competitive impact is overstated. It's almost more information than you want out there if your goal is to foster competition. If I were a hospital and I could do it, what I would focus on is this on the shoppable services disclosure. I would focus on whether I could put up a price estimator tool of the type that we've been talking about, where a patient can specifically put in information about their plan, what they need, and get, some level of reliable answer as to what their out-of-pocket is going to be, because that's what people want to know. And I think a hospital that can do that can satisfy the requirement that way, it's not that pricing has no influence on people's decisions, and it certainly has more as people have gotten more focused on out-of-pocket cost and out-of-network charges and that sort of thing. But it's just not the fundamental way most consumers shop for hospital services. And so I think, again, the thing that annoys me about this is you're looking at a fairly significant cost to the system in putting this up. I don't think that cost is going to be repaid in actual consumer benefits.
Another question: what will large self-insured employer groups take this information to help their employees?
They are going to be more price sensitive because they're paying these costs out over a large pool of people, and they, at least hypothetically, have the ability to have internal folks or hire consultants who can interpret it for them. So I think it's marginally more useful in that setting, but I think it depends a lot on what kind of employer you're talking about and sort of how active that employer is.
I think Bill's right. The answer is going to be it depends. And you've got large national employer groups that are self-insured that are already doing those sorts of things with big ticket items, where they do contract with national health insurance providers outside of their area for things like transplant or cancer treatment or things of that sort. You may see some increased use of that. By and large, it will depend on the employer. I would agree with Bill.
One more question. Is there any legal issue with allowing an insured patient to be treated as self-pay if they choose to be based on high deductibles?
It depends on the provider. In the situation, and let me put it in an analogy that's I've got a car insurance policy with $1,000 deductible. If I have a fender bender where the damage is less than $1,000, I may well say to the other person, look, why don't I just pay you the $750 it's going to cost to get your bumper fixed, And that way I don't have to file a claim with my insurance company. It doesn't, go against my premium. By analogy, if you had a patient who came to you and said, gee, I've got this big out of pocket, how about if I just pay you XYZ, would you sell me the service on a cash pay basis? Technically, if you're in network with that patient's payer, you violated the provider agreement and you could be subject to termination as a provider.
There's one more question. Will this get linked at some point to the surprise billing efforts?
The complaints of people who say, well, I went to this hospital because it was in network, but I went to the emergency room and the ER docs weren't in network. And so I got a bill for $5,000 for, having somebody look at my sprained ankle, and I don't understand this. Sort of psychologically, you are going to see some linkage to that. And I think one of the challenges with this disclosure is, even though you are supposed to put up in the consumer-facing disclosure an indication of what isn't paid for as part of your hospital bill for a particular condition, that's going to be hard for people to understand.
The recent price transparency rule has created upcoming challenges for hospitals and their billing practices. Although this is a new specific rule, the concept goes back as far as 2006, when the CMS, Centers for Medicare and Medicaid Services, began publishing prices. In 2006, 100 common procedures were listed, but the way it was given was found to be too confusing for people who didn't have a medical background. It was hard for them to find the pricing they were searching for. The 2019 rule has added two very important criteria to the listing of pricing and rates for common procedures. First, it must be machine-readable list, or data in a format that can be easily processed by a computer without human intervention, while ensuring no semantic meaning is lost. This is from the Open Government Act of January 2019. Secondly, it must be consumer-friendly and include a web-based estimator tool that doesn't have identifiers required to access it, which means people should be able to find your prices on the internet without having to log in to see them. Benefits of this rule primarily apply to the underinsured or those with high deductible plans. Although there are going to be many who find better healthcare because of these rules, it's still a challenge for many patients for these reasons. Some people don't want to shop around because it creates more work and takes more time. Some people aren't as concerned with prices but would like to find a provider near their location. Overall, hospitals also face challenges with setting up this system, such as manpower required to maintain it, bandwidth to manage the internet and IT needs, and having to list multiple rates and situations for each case. But it will incentivize providers to provide better and more affordable care. It'll also incentivize patients to be better and more informed consumers of their healthcare. One way to prepare for what may be upcoming changes in the healthcare world is to learn how to price compare for your own healthcare needs right now, using tools like ZTool. ZTool is one way hospitals can make their information compliant with CMS by creating a seamless way for people to shop and price compare common procedures. If you're a hospital administrator and are interested in using ZTool for your healthcare needs, check us out on ztool.com.